Hello everybody, the title of my talk is Traumatic Brain Injury in Low and Middle Income Countries, and I'm talking on behalf of the NIHR Global Health Research Group on neurotrauma. I have no conflicts to declare. A traumatic brain injury is a pathway for a patient from the scene of an incident through emergency department, operating theatre, ITU, rehabilitation and reintegration into the community. Nearly 90% of traumatic brain injuries occur in low and middle income countries, and trauma causes approximately 14,000 deaths per day on the planet, many of these as a result of traumatic brain injury. In high income countries, there are many things we take for granted. These include pre-hospital care with access to ambulances, helicopters, sophisticated trauma networks. But in low and middle income countries, this access is not universally available, and for example in Randy Chestnut's trial of ICP monitoring in traumatic brain injury, only 45% of patients were actually transported to the first hospital by ambulance. Another technology that we take for granted is CT scan, widely available, and we have the NICE guidelines to tell us when to perform a CT scan following brain trauma. In low and middle income countries, when to perform a CT scan depends on access, funding, and in many places those limited to one scan per patient. We also in neurointensive care have access to sophisticated bedside monitoring, starting with intracranial pressure, but now with other monitors added. Randy Chestnut in his trial showed, however, that you could manage intracranial pressure without ICP monitoring, using care focused on maintaining a monitored ICP at 20 millimeters of mercury or less was not shown to be superior to care based on imaging and clinical examination. So it is possible to manage patients well without access to these technologies. Also, what about surgery? So when we were undertaking a potential trial of hinge craniotomy in Zambia, what we were conscious of, what they really needed was access to the sorts of drills, craniotomes that we are used to. And also rehabilitation, fundamentally important, again, often very good access in high income countries, but deficient in low middle income countries. On the background of that, we have formed the NIHR Global Health Research Group on Neurotrauma. This is funded from ODA money from the UK government. We know that traumatic injury is increasing worldwide, with the greatest increase in low middle income countries. Neurological injury is one of the most catastrophic, and good quality neurotrauma care is complex, and if we're going to improve care, we need to provide high quality data. So we joined together with a number of partners, various low middle income countries and collaborators globally to start this group, which comprises 4 themes. The first theme 1, is about data collection, the Global Neurotrauma Outcome Study GENOS, which will lead on to a registry, TBI, more detailed registries, for example in Zambia, and a particular emphasis on prevention. This is Lawrence of Arabia, who died on his motorcycle with no helmet in 1934. So Hugh Cairns introduced the motorcycle helmet, but there are many places in the world where motorcycle helmets are not in use. The GENOS study has recently finished analysis and being submitted for publication. This was a snapshot study looking at the management of surgery for head injury across the planet, looking at differences in patient demographics, indications for surgery, the choice of procedure, peri- and post-operative care, to compare practice globally to accepted standards of care for the surgical management of TBI. Theme 2 used a systems engineering approach to model the current management of TBI in one particular healthcare system, Yangon General Hospital in Myanmar. Using a systems engineering approach, we modelled what the effect would be on change before actually implementing that change. And this is a technology that can actually, I think, be very helpful in a very efficient way to improving healthcare systems for the management of trauma and other pathologies. Theme 3 is innovation in traumatic brain injury care, and looking at new technologies and new approaches, including data collection and rehabilitation. And examples on theme 3 is how can we detect intracerebral hematoma, I've already alluded, CT scanning is something that we all take for granted. Started in hospital, became portable, in some places now in ambulances, but we can refine technology, use other technologies to detect intracerebral hematoma. This is the infrascanner device, and we've currently just completed a study of infrascanner in Latin America to see whether this technology can actually detect hematomas requiring surgery when CT scans are not available. What about intracranial pressure monitoring? So again, this is something that, as I said, we take for granted, but it is possible to get a surrogate measure of intracranial pressure through ultrasound. We can measure the optic nerve sheath diameter, that correlates to ICP. Ultrasound, again, an expensive technology, but can actually be miniaturized now. This is the Philips Lumini probe, which can be connected to a smartphone for its display. Theme 3 also explores the role of families can play in the monitoring of consciousness. So we've been able to teach families to help with their nursing care, but also with the rehabilitation of patients where this is deficient in various parts of the world. How do we follow up patients? Well, classically in high-income countries, we've used the postal service. Postal addresses are not often available in many parts of the world, so we can look at perhaps using an app. Smartphones, again, not university available, but what many people have is a standard mobile phone, and we have now developed an SMS text messaging service to calculate the extended Glasgow outcome score in patients following traumatic brain injury, and that is something that was designed for use in Africa, but we're actually pioneering that in the UK. And theme 4 is how we can build research capacity, publication output from low and middle income countries and implement formal research skills teaching, and that we're doing in collaboration with the BMJ, a strategy called Strengthening Research Output. And part of that is this study that we've conducted on qualitative approach. This is led by one of my colleagues, Charlie Whiffin, and what we've been looking at is the inhibitors to undertaking research in low and middle income countries and how we can stimulate them to actually get low and middle income countries to lead some of these research projects. And that is leading to some very fruitful outputs. This is Bootstrap Beyond One option for the treatment of severe traumatic brain injury, where we can begin to use data to produce algorithms for the management of traumatic brain injury tailored to different healthcare settings. But beyond academic output, we can begin to look at how we can influence healthcare internationally. And one way of doing that is through lobbying governments. And there is a potential mechanism. The World Health Assembly meets annually in Geneva. It is attended by all approximately 190 health ministries globally. And there is a forum there where you can present and lobby these governments in terms of the importance of various conditions. And that's something we've started to do for neurosurgery, collaboration with the WFNS. Meet government ministers, explain the issues, and that is beginning to bear fruit. We have been able to increase the number of neurosurgeons in Zambia. The academic outputs from the group, there are 14 partner institutions, a local, national and international range of research projects ranging from public health to clinical trials. Really important to support research fellows in low and middle income countries. And the group has now produced over 50 peer-reviewed publications and presented at over 40 national and international conferences. But it goes beyond academic output. This is about policy change and improving the management of patients by advocating at international, national and local levels, drawing up guidelines appropriate to partner countries, informing national policy, engaging in surface redesign, training and clinical mentorship, research capacity building, and engaging the next generation with strong medical student engagement. I'd like to acknowledge and thank our partners within the group, but also the many collaborators globally, particularly through the GENOS study. we're all working together to try and improve the management of this condition across the world. Thank you.